Welcome to our podcast, Journey into the Future of Medicine. I'm your host, Bill Maggio, Chief Executive Officer of the Jacobs Institute. We are a nonprofit medical device innovation center here in Buffalo, New York. Here we talk about what is possible in the next quarter century of medicine and healthcare, based on a report we published titled The Future of Medicine.
Due to COVID-19, this episode was recorded through an online platform, which accounts for differences in sound quality. Dr. Schweitzberg is a professor and chairman of the Department of Surgery at the University of Buffalo Jacobs School of Medicine and Biomedical Sciences. He is the former chief of surgery at the Cambridge Health Alliance and professor of surgery at Harvard Medical School. Dr. Schweitzberg is the past president of the Society of American Gastrointestinal and Endoscopic Surgeons. He is the multimedia editor for surgical endoscopy and is on the editorial boards of several other surgical journals. Dr. Schweitzberg is a recipient of several awards for patient care and a Computer Award Laureate Award for introducing surgical video editing into postgraduate education. He holds 2 patents, has written more than 120 articles, 12 books, and is currently editing 2 books. Dr. Schweitzberg, welcome.
Thank you.
So I got to begin. You've been with us in Buffalo for almost 5 years now. With some of your reputation, why did you choose Buffalo?
Well, the changes in Western New York are incredibly exciting. And I've loved living in Boston. And what I was really looking for was an improvement in my day-to-day quality of life. I used to commute an hour and a half each way. And my commute went from an hour and a half to 4 minutes when I first arrived living downtown, and I doubled it all the way to 8 minutes living in Delaware Park. And it's just really a nice place to live. And I was looking for new challenges, and my wife was looking for new challenges, and we really thought this would be the ideal place.
I remember still how excited we were all to have you join us here in Buffalo, and you've had such a huge impact on the medical campus, and we're so fortunate to have you here. So modern surgery has come so far from the early days before anesthesia, aseptics, and so on and so forth. It continues to evolve and advance. And we released at the Jacobs Institute a report in 2017 called The Future of Medicine, as you know. And there's actually a chapter called The Future of Surgery. And it explores the role of robotics. Even before COVID, robots and robotic units were moving into operating rooms, both assisting surgeries and actually performing some surgeries, such as placing electrodes in the brain or assisting in knee and hip replacement. Can you share for our listeners other examples of what robots are already doing in operating rooms today?
Well, we're doing a wide variety of general surgery, cancer surgery, bariatric surgery, colon surgery, hernia surgery, gallbladder surgery, with robots. There has been a dominant player in the market for decades, and yet we're starting to see many companies wanting to provide that level of precision surgery, and I think we're going to see more competition. So what is the principles behind that? What does robotics really do for us? Everybody knows that it costs more, but what do you get what is the value that you get in return? Well, number one, you get precision, that there's no tremor. You get scaling. You get measurement of motion. You get degrees of freedom that our current minimally invasive operations and the instruments that we use for them don't have. So we currently, for instance, I use essentially a chopstick in the abdomen. Now I have a wrist. And so there's a lot of things that you can do with that. And just like the forefront of any technology, whether it was your home computer that, cost $3,000 20 years ago, you can buy computers for $300 that do 10 times more today. The surgical robotics will be part of that trend. It's unstoppable. And so I think we'll see more robots on the market. We certainly see it in orthopedics. We certainly see some aspects of robotics in neurosurgery. We see some of that in ear, nose, and throat surgery, and even removing tumors transrectally and things like that. We're seeing more and more of what we can do. We've got to stake out the value proposition. We have to measure the outcomes, because the other side of the coin is we're going to have to do these operations in the most cost-effective way possible without sacrificing all of the gains that we've made in precision. Like, we're not going back to just needle and thread. So our challenge will be, how do we harness the value of technology? For me, one of the ways we harness it is through competition. And so I think that helping companies through our work at UB Rise and partnering with the JI is really critical. And I think it also makes the market leaders better. We are all made better by competition. Competition forces creativity the same way COVID has forced us to be creative.
Right, right. But you don't ever see a time where surgery will completely transition to robots. And I mean, that's not something in our near future, correct? I mean, there's so many people who think that, but that's not the case.
Well, we've been at this for 20 years, and we're at probably somewhere between 5 and 8% penetration of robots in the general surgery market. There will always be people who have a lot of previous surgeries, who have adhesions, for whom it's very hard to get the robot inside the abdomen. It really creates one of the challenges when you have all these toys. What happens to the basics? So
right.
when every kid could add on a pencil and paper, what happened to their adding skills when the calculator came along, and then the personal computer? What I believe is that a lot of the technology in the middle drops out, but we will always need the basics and always want to be at the forefront at the same time. So even if you're a robot surgeon, you still need to be able to cut, sew, and tie.
Yeah, it's such an interesting point that you make, because I would suspect that no matter how advanced we get, how you teach young medical students how to be doctors is not going to change, right? I mean, they got to learn the basics.
So I'm a pilot and learned to fly a small plane, but understand that every jet pilot and every airline pilot that you've ever met also started off in the same small plane that I never actually progressed from. But, and that's going to be true in surgery too. The basics of whether it's flight or surgery or diagnostics or patient care are crucial to creating good doctors. And we won't always have the technology in a mass casualty situation or a crisis, a flood, a war. I had the pleasure and honor of serving my country in the Middle East, and I was looking at, hundreds of patients and no CAT scans. Well, you tell somebody today you don't have a CAT scan, they get really worried that they can perform, but they'll be okay if they have the basics.
So true. At one of our first Future of Medicine events in 2018 that we hosted at the University of Buffalo, you mentioned that you were also working to advance augmented reality, or AR, technology in surgery. Can you tell our listeners what AR is so they have a little better understanding about your work?
AR sort of sits in between real reality and virtual reality. Our team has done a fair amount of work in virtual reality, a lot of programming, a lot of processing power. Augmented reality harnesses some of the baseline imaging and things that we see that are real, and then creates overlays of additional information. Think of Google Lens. You take a picture of something and it kind of tells you what it is. So merging the CAT scans with the physical imagery, getting more information out of it, helping us see the blood vessels more effectively, are really how we augment the reality to provide more information, greater safety for the care of our surgical patients.
It's fascinating to me. I just have to ask you, how are things going at the UB Jacobs School of Medicine, in terms of just ramping up amidst all this COVID stuff? I mean, how are you guys making out so far?
It's a real challenge. We discuss it at high levels. My wife, who's the associate dean for curriculum, works on a team of trying to provide a safe environment for not only the medical students, but the 30,000 students that are arriving at the campus. As we were sort of winding down through the acute ICU emergencies in the hospital, the school was just getting ramped up with how are we going to bring all these students back to school, and how are we going to bring them back into the hospital. When COVID hit, all the medical students were vacated from the hospital. How do you bring them back? How do you protect their safety? and working through those issues as essential employees or not. What is the role of a student versus a resident versus a faculty member? These are all incredibly difficult. If we're expert at having auditoriums full of people and then we break up into small groups, how do you do that safely in the land of COVID? If you listen around the country, you see how hard this is. You look at the University of North Carolina, where they were bringing all the students on campus. 2 weeks later, guess what? They sent them all home. And so the team at UB and the medical school working really very hard, thoughtfully, trying to be nimble, is trying to provide the safest possible environment. You know, you can teach many things on Zoom. Kind of hard to teach somebody to be a doctor on Zoom, really. So their challenges, and I think they're up to it, trying to provide safety has been their number one goal. I think they're doing a good job.
That's great. Well, best of luck to you in that regard. It's just an aside on one of your comments. So how impactful was it to the students, you know, in the second semester last year or I guess earlier this year, I should say, when it kind of hit its peak here? I mean, the kids been able to catch up, the students been able to get caught up?
Well, you have to make choices. So it was for the clinical students, it was the hardest. Right. The other students, you could pivot. My wife went from a live lecture series to a completely virtual lecture series, working day and night. I think one of the things that, you know, message to the students, many of your professors have been working day and night to realign their educational efforts. Everybody's at this for the first time. It's not going to be perfect. The first iPhone wasn't perfect. We will get better at this over time. For the students that are in the hospital, it's a unique set of challenges since we didn't have the protective gear to be able to give to students just for the purpose of education. We had barely enough to take care of patients, so they got sent home. And so when we finally got people back in June, we had students who had not finished their third-year rotations who had to now be overlapped with other third-year students who were starting their third-year rotations, overlapped with fourth-year students who were doing their electives to get ready for their residency applications. And we've really had to work hard at trying to provide the best experience we can provide. In medical school, the fourth-year students all travel to the places that they want to interview. If you want to go to Pittsburgh or California or Boston, where have you, or come here, all these traveling rotations, gone. All of these visits to the campus to see whether I like it, to interview, gone. It will all be done virtually because we have no choice. And people are getting really creative. We're putting on virtual, you know, open houses in addition to our virtual interviews. And, you know, having just come back from the SAGES meeting, which was done virtually, I was asked by Doc Simity to write a piece on what I thought about the virtual meeting from a standpoint of having run the meeting, been the president and all that. And I thought the SAGES team, just like our UB team, responded to the challenge and did great. However, if you ask me, do I want to go all virtual in the future? There's something about human contact and socialization and catching things on the fly and walking the exhibit hall that we're a long ways from duplicating virtually. And we'll learn things. So like our poster session, all digital. That was great. You could tweet, you could email. Right. There are things we want to keep moving forward. But I think human contact is important.
Right. I would agree. So, you know, with so much changing around us as a result of this, one has to wonder, you know, really, how has surgery in hospitals changed as a result of COVID, in your opinion?
Wow. It has been really
very broad question. Yeah.
Pretty broad question. Well, first of all, as you know, every state has sort of responded to this, and the headline articles about hospitals stopping elective surgery. So I want to get and add some clarity. Not every surgery that we do that is not the result of rushing somebody up from the emergency room is elective surgery. So I want to change the dialogue to words like emergent surgery, urgent surgery, scheduled surgery, and then there will be things that are truly elective. So the challenge for myself and and Kevin Gibbon, who, been a senior surgical leader here forever, Ken Snyder, folks like Jeff Fisco, David Rothstein, Mac Harmon, was to actually, stand at the gate and try to figure out what can we put in the operating room safely in terms of patient safety, staff safety, versus balancing that against the need of delaying surgery. So unless you have a gunshot wound or a stroke or something, a lot of things can be delayed and a week doesn't matter. But when a week turns into a month, turns into 3 months, things that seemed to meet that term elective that gets thrown around too easily becomes less elective. If somebody said to me, well, we didn't need to do colonoscopy, that's elective. Well, this week it's elective. But when you're 4 months behind on colonoscopy, and I can tell you I met a practitioner who got 700 colonoscopies behind. If we know that the cancer rate's about 1 in 100, that's 7 people with colon cancer who haven't been diagnosed yet. And so we want to change the conversation from elective surgery to a more thoughtful way of prioritizing what needs to be done. The shutting down of the ASCs, and in full disclosure, I don't operate in an ASC, so it's not about what I do, but that's like the safest place to be. It turns out, in retrospect, we could have kept our ASCs going. We didn't know. I'm absolutely not criticizing the decisions to close them that were made, very heartfelt, very thoughtful in real time. But if we have these little ripples, second, third, fourth waves, could we keep our ambulatory surgery centers open? I believe so, if we have the personal protective gear to support it. It is very hard to start an operating room back up. It's actually really easy to close it. You just stop. So if the situation changed, we could close down the ASCs literally in 24 hours. Getting all those people rescheduled, reevaluated, retested is a nightmare. The other big piece for us was the COVID testing. With a lot of thought, we felt that it was unsafe to operate on people unless we knew their COVID status. Even just putting somebody to sleep is a high-risk procedure because our anesthesia team and others are in front of the airway, being at risk. So COVID testing is mandatory. How do you test thousands of people? These are big lift items. How long is the test good for? What happens if you accidentally operate on a COVID positive patient? We know the results are worse. So you don't want to do less emergent and less urgent surgery for people that might be COVID positive. And then trying to figure out who's on the other end of the scale, who do you not need to test? That gets hard too. So the blanket statement is everybody getting a procedure gets a test. And so that's what we're working through and trying to figure out how to meet that mandate and keep everybody safe.
I would suspect that, like in all situations that are bad, good does come. And it sounds to me like we continue to find ways to deal with the current situation, but we're going to come out of this thing a more efficient operation going forward. And having someone who lives in Western New York, I've been so impressed with how the healthcare community has kept our community so safe, and I'm very grateful for that. Before we move into the closing segment of our discussion today, you have just such a vast and wonderful reputation. Can you just give us kind of your snapshot on what you think the future holds of COVID? I mean, what are the next 6 months going to look like, in your opinion?
I think we're all really worried what happens when people go back to school. I don't want to be a downer on watching, kids walk down the street and they're not socially distancing, but I think we're already starting to see the impact. It's public knowledge that there's already 2 medical students who have COVID. We're very worried. Contact tracing is going to be critical. We're not caught flat-footed the way we were when this disease first started up. Masking really does work. We realize this is not the zombie apocalypse, and one little virus on a door handle does not make you get the disease the next day. And so really understanding how we can bring people back to school, how we can jumpstart certain aspects of the economy that are badly needed if we can do this safely. So I don't think we're going to have a big spike, but I think we're going to have a couple ripples. I'm paraphrasing paraphrasing Peter Winkelstein, who is our director of medical informatics at Kaleida, and just says there's going to be ripples, and we're going to see little spikes, and the information is so confusing on the news. And I've been in countless meetings about incidence and prevalence and testing numbers, and I want to sort of leave some clarity on this to help understand it from a health system point of view. You could have whatever number prevalence of testing that makes the newspaper this week. Did they batch them all on Monday because they didn't run any over the weekend? But if you really want to assess how we're doing, look at hospitalizations. And furthermore, look at number of people in the ICU. That really tells you what your threat for the hospital being overrun is. We run a full hospital all the time. We run full ICUs during flu season. And so unless you understand what the real metrics are that put the health system at real risk, which is ICU admissions and patients on ventilators and things like that, then whether the prevalence is 1.5 or 1.8 or 2.1 or 0.9, a lot of that is noise. It's just all low. If we start finding that we're putting ICUs, in the hallways again and things like that, then we're really in trouble. I mean, that's a metric that everybody can follow. And we need to be data-driven because not every therapy is harmless. Everything we do has a risk. Even drugs that are considered safe in their clinical trials had some nasty side effects, rarely, but they do happen. So giving inappropriate therapy is not a good idea. There are horror stories all over the news of people who took fish tank cleaner because they saw that it had chloroquine in it and died, husband and wife team. And so we really want to be evidence-based. We really want to have the best medicine, which is prevention, and so that we have time to get to a effective vaccine therapy. And if the public helps us, then we'll all get through this together.
Very well said. Very, very well said. Thank you for that, Doctor. So let's close with a few rapid fire questions so our listeners can get to know you a little bit. So I'm going to go ahead and just fire these questions off to you. So after COVID, where's the first place you want to travel to?
I want to go with my wife somewhere on a beach where my cell phone doesn't work.
Good for you. If you hadn't become a surgeon, I should say a great surgeon, what other occupation would you have chosen?
I probably might have wanted to be a pilot in my early days. I had a pilot's license when I was 17, which is pretty early. But through the act of surgery and doing video and surgery and things like that, I actually would have really liked to have made movies.
Okay. You kind of caught me off guard on that one. What's the last place you ordered takeout food from?
Indian food from the Taj on Delaware Avenue.
Okay. And what makes you mad?
I think when people don't care, that makes me mad. What makes me mad is when people are walking down the street and they don't care. They may feel, I mean, an example of this, they may feel like they're not going to die from COVID, but what about their mom? What about their grandma? What about their aunt? What about their friend? What about their good friend with asthma? Not caring makes me mad.
Well said. Doctor, it was a pleasure to have you with us today. And I just want to close by telling you, we're all so grateful to have you here in our Western New York community and so grateful for your time today. Thank you so much.
Thank you.
To our listeners, thank you so much. Until the next time, good day. If you enjoyed this podcast and want to be the first to know when there is a new episode, make sure to subscribe and recommend to a family member, friend, colleague, or your social media followers.